we'll be moving to the most important imaging sessions. So in this context, we have two international eminent pioneer chairpersons. I would invite Dr. Naveen C. Nanda from Alabama and Dr. Y.S. Chandrasekhar from Minnesota, then Dr. Sanjaya Biswamitra from Bangalore, Dr. Sanjay Gambhir from SGPGI Lucknow. Over to the chairpersons, please.
Pleasure for me to be invited to this Heart Failure Summit. It's past midnight here on Saturday night, but I think we're still fresh here. And maybe we'll start the session with Dr. Satish Govind. As you know, he is one of the leading cardiologists in India, and also has been the president of the Indian Academy of Echocardiography from Bangalore. And his topic is going to be role of 3D echo and GLS, global longitudinal strain, in heart failure. So up to Dr. Satish Govind.
Thank you for the welcome. And let me sort of straight away get into this key area of 3D echo and GLS. And this is in the heart failure. So I will touch upon some brief sort of areas where it makes a difference. Now, traditionally, we have used the 2D LVEF and then the LA sizing and then the TAPSE over a long period of time. So with the onset of newer applications, the focus is more now on LVEF in terms of 3D, the volumes, and then there are LA volumes which are now available on 3D. And then you also have RV 3D also available now. And when it comes to the speckle, there is LVGLS, which is well accepted and validated, and there is also focus on RV strain and LA strain. So these are the ones, and my focus will be on the 3D EF and the LVGLS. As early as 2016 in the ESC guidelines, there is the first mention of when strain should be used. So this is in the preclinical stage. So this gets a 2A recommendation at this point. And in the recent ACC guidelines, there is mention of reduced strain, and this gets a lot of prominence here. And this is in the stage B, that is the pre-heart failure stage. So reduced strain gets a very big sort of tag here. And there are some cutoffs which are, when it comes to the LVEF, the 2D, it is the around 50%, but the LVGLS, there is a clear cutoff of around 16%. This is primarily for heart failure with the preserved ejection fraction. Now, just sort of a focus on 3D. So when it comes to 3D, when it comes to the EF itself, the decision making is mainly for classification of the heart failure, the risk assessment, and then looking at some key sort of implantations in terms of ICD CRT. So this is the parameter which sort of decides in these key areas. And 2D, as we all know, has some limitations. So with the advent of 3D now, it has got a boost, and we are sort of much more confident in classifying these patients and taking clinical decisions. And LA volume is also now available. So this especially would be very useful for the heart failure with preserved ejection fraction. Now, this is a brief sort of comparison of how the 3D versus 2D, and how 3D sort of is much more superior when it comes to the 2D itself. So this is a meta-analysis which looks at almost around 10 studies, and primarily looking at the correlation here. So this is the LV-EDV, the EF, and then the blind Altman values, when in comparison with the 2D shows very high correlation with the CMR, and also the blind Altman values are quite low here. So indicating that it is well validated and reliable in heart failure and can be used. Other area is the RVEF itself. So how well can it be used? So this is a recent sort of an abstract presented at the 2020 ESC. So looking at the role of RV3D and as the predictor. So this was on 140 plus patients, and the follow-up was somewhere around 37 plus minus 16 months, and they looked at primary outcomes and secondary outcomes, and they found that the RVEF was an independent predictor for death and hospitalization. So very clear sort of message here. So best predictor for death in patients with heart failure with reduced ejection fraction. So this is the comparison of the R value, modest, but still compared to the other traditional values, which is much, much better here. A look at how can we use 3D in terms of follow-up. So this is again a very sort of a nice and a practical approach as to how 3D can be used, looking at trainees. So it's a large busy lab where the focus was on looking at the in trainees. So these trainees received about 1 month of training, and then they sort of followed them up, and they found that 3D was a much more feasible and more reliable method when compared to the 2D itself for follow-up of heart failure with reserved ejection fraction. And this especially when we have dilated and distorted left ventricles, we know that 2D EF is not so accurate. So this is again a nice message of where it can be used as a follow-up with the sort of very sort of 1 month expertise itself transforms into quite a reliable way of approaching the EF calculation. So 3D assessment, reliable and validated, and this is in the clinical setting. And when it comes to preserved ejection fraction, it gets a quote here in the document that 3D can be used and should be used, and it should not be estimated. And when it comes to the RV, EF and volumes, LA volumes, these are emerging parameters. More data would be welcome. And there's also mention in the literature about using the sphericity index, looking at the RV, the LV remodeling. And this is rather than doing a direct measurement using the 3D volumes itself. So to some extent, it has been shown to be reliable, much more superior. Dyssynchrony index has been sort of discussed, but not really sort of seen much headway, and a very sort of limited focus when it comes to 3D and transcatheter interventions when there's heart failure, and also looking at mitral regurgitation, especially in secondary MR. Now, coming to the role of GLS. So this is GLS. So this is a very sort of a simple sort of way of looking at GLS in terms of how it declines over a period of time. As it keeps declining, circumferential fiber starts to compensate, and over a period of time, even the circumferential strain starts to decline, and that's when the LVEF comes down. So this is typically how these patients progress. And we have the GLS, which is more sort of available on the machines. GCS is still sort of not come in a regular way as far as the commercial software is concerned. Just again, cherry-picked a few sort of articles looking at the GLS. So there is an enormous amount of literature on the LV-GLS. So this is just looking at the all-cause mortality. So looking at the GLS in terms of the reduced ejection fraction, and looking at 1,000 patients here, and they looked at a multivariable model, and no other parameters remained an independent predictor. And this had the highest C statistics. That means even the randomly sort of selected patients had the best outcome in terms of how we can choose it, and it had incremental prognostic value. So as an independent predictor, so it is very reliable for all-cause mortality in heart failure with reduced ejection fraction, and this was superior compared to the other ECMO parameters. Now, when it comes to arrhythmic events, so this is, again, we know that it is proven in terms of ischemic cardiomyopathy, dilated and hypertrophic cardiomyopathy. So this was in structural heart disease. So this was a study looked at, and this was an observational study, and looking at around 200 patients, and they put an ICD here, and they followed them up after 2+ years, and they found that the first event, after the ICD, so this was quite reliable in predicting it. So again, LV-GLS in arrhythmia has been shown to be a parameter which can be able to predict the first event after ICD therapy. And the cutoff values here, so ICD therapies, 6.7 here, and then the ventricular arrhythmia is around 7. 7. So these were the values quoted here. And the other area is cardiotoxicity, where it is well known that it can be used to look at especially the subclinical decline, where it is much more sensitive in terms of looking at the functional decline of the LV function, the LV function itself. Then there is a lot of data on ARNI. So this is again a simple study, but reflects a lot of other studies also. A small number, 30 patients who were treated with ARNI, and they compared it with the ventricular volumes, and they found that the GLS was much more sensitive in looking at early sort of improvement. So at the end of 3 months, the EF was not able to identify, but GLS was able to identify an improvement in the LV function. So the conclusion was it's a practical tool to assess early and minimal variations in LV systolic function. So this shows the GLS improving at 3 months, and how it is a much better tool compared to the EF itself. Then what about the right ventricular strain? So there is some data on right ventricular strain also. This is as early as 2015, and where the 600 patients were looked at, and they compared with a lot of other parameters in terms of both LV and RV strain, and they found that the free wall strain was a predictor of cardiac events, and this was in a group of patients with acute decompensated heart failure. So the free wall strain, the value was somewhere around 13%. So again, the emphasis is on the right ventricular strain. So overall, this sort of summarizes how we should look at heart failure patients, especially with a reduced ejection fraction. So looking at EF, looking at GLS, and then the RV function, and all these parameters which I quoted should be used to identify these patients, because they have very high mortality when they have these bad values. And now moving on to looking at both the preserved ejection fraction and reduced ejection fractions. So these are some of the values. Again, I have it's a long table, so I've just edited out and shown only these three. So you have reduced ejection fraction, preserved, and then the ICD here, 400 patients, and the numbers here. So 6 and around 9.6 here for the reduced ejection fraction, and around 16 here for preserved, and then less than 10 for ICD, the ICD patients here. Now, moving on to preserved ejection fraction. So this again is looking at multiple studies here, and the number which sort of really pops up is around 16, and this is the number which is quoted in the document where the LV-GLS should be used as a cutoff for heart failure with preserved ejection fraction diagnosis, and this is a minor criteria, so the number is 16%. And again, this study here shows how the strains starts to decline as the BNP keeps going up. So there is a correlation with BNP also. And this is an algorithm in the document by the ESC here. So shows how it can be integrated into a scoring system. So there is the GLS of 16% here used as a minor criteria. Just a brief look at a patient as to how it can be helpful. So here is a patient, a 69-year-old, hypertension, diabetes, comorbidities, and found to have heart failure with preserved ejection fraction. And these are typical sort of echo images seen in these patients with the preserved ejection fraction. These are standard values where they're all abnormal. And the LV diastolic dysfunction, the E by E prime shows increased LV filling pressure here. And the GLS is where it tells you that this patient is on a rapid decline here. So there's already a decline in the LV GLS, and then the circumferential strain is also come down here. So we know that this patient is not going to do well. So this is how it can be utilized. Now, the GLS and exercise in preserved ejection fraction, again, shows that when it comes to looking at the exercise capacity, the LV-GLS correlated very nicely with the peak VO2, and it was superior in identifying patients with reduced exercise capacity. So this is, again, a very nice sort of a study looking at exercise and LV-GLS. And you can look at the area under the curve here, so quite high for LV-GLS, around 0.93 here. So this again emphasizes it is superior to other parameters to identify patients with the peak VO2 of less than 20 ml. Then RV-GLS. So RV-GLS also has shown to be good. So this is a study with around close to 150 patients. So again, shows impaired RV-GLS, very strong prognostic value, and it should be considered for systematic evaluation to predict high risk for adverse events. So RV-GLS also should be be integrated into clinical routine. Again, more data would be welcome to get a better sort of value. There's always this controversy of whether one should use the free wall strain or whether it should be combined with the septum also. So this is just a comparison of how to look at the GLS in terms of subclinical and overt failure. So you can see that the GLS progressively declines as the stage in heart failure worsens, and the circumferential strain initially is normal, compensates, and over a period of time, this also declines here. So this is the algorithm. So looking at how one can look at the utility of GLS. So you have preserved ejection fraction, reduced ejection fraction, and looking at these various areas of increased risk and then in terms of hospitalization. Yes, please, I'm almost there. And looking at trial patient selection, looking at lead placement, and also potential reclassification in terms of the staging of the heart failure. So this is where the utility of GLS is. So this would be my sort of last slide, looking at the parameters vis-a-vis the GLS versus EF. So a lot of advantages. Early sort of impairment can be detected, superior, and in terms of loading conditions, less significant, highly feasible, and the variations are much less when compared to EF, and the correlations are quite good. And 3D EF, when compared to the 2D, has less observer variability and better correlation also. So all in all, so the EF by 3D, the volumes are much more reliable and much more, should be used more frequently. And the LV-GLS should be used also quite frequently, look at various areas. Thank you.
Thank you, Dr. Nanda. Dr. Govind, that's a fantastic talk. And you gave a wonderful description on GLS and echo.